So, dear trainees, welcome and thank you for being here today. I'm Navneet Singh, your host for this webinar. I know that today's topic might bring up a number of questions from you. So, you may type your questions in chat box, and I want to let you know that we will address as many as we can in the time we have today. And I welcome and request our NBMS National Webinar Coordinator, Professor Dr. Somashekhar, to start this session. Thank you, and over to you, sir.
Thank you very much, Navneet Singh ji. Dear trainees, welcome. You know that it is very difficult to get a excellent medical oncologist to cover a topic. Last month, when I took a poll and discussion and advice from all of you, most of you requested, sir, we are not aware much about the general principles of immunotherapy, pros and cons, which cancer we need to use immunotherapy, difference between driver mutation targeted therapy, anti-angiogenic therapy, immunotherapy to be used in head and neck, RCCs, and many other solid tumor, G junction, everything. So as per your request, I got somebody who is a pioneer in this field of immunotherapy, had been using extensively over last 5 to 6 years. Above all, highly knowledgeable and very well read and an excellent speaker, Dr. Amit, head of department, Manipal Comprehensive Cancer Center, head of molecular, and immunotherapy division, medical oncology. Please make use of this particular topic. At the end of it, ask as many doubts, question you have in chat box. We get opportunity that cross colleagues, medical pathology, very good talk to us, and that's not easy to compromise all their time clinical benefit. So please actively participate, take very good opportunity, ask all the doubts, how much ever silly it may appear, which may help you in both theory, exam, and practical. Thank you very much, Amit, for accepting invitation on behalf of NBE and DNB board and myself and students. And over to you, Amit.
Thank you, Dr. Somshekhar. Thank you for giving me this invitation. So let me kind of start off with our topic. So what we are going to do today is we are going to cover immunotherapy in cancer treatment. Good morning, everyone. I don't know how many are here, but what we'll quickly do is I will run you from basics of immunotherapy to where we are now in cancer management and also show you why we are so fascinated with immunotherapy. So there have been multiple advances in medical oncology. We always said we moved from the chemotherapy era to slowly the biological therapy era, but then the targeted therapy era, and now we are in the immunotherapy era. So what are these steps which we have taken? The first steps were supportive care got better. We got better growth factors. We were able to give higher doses of drugs and in a better manner so that patients didn't have that much toxicity, but that was more for supporting patients during chemotherapy. The newer chemotherapy drugs were very limited. We have reached a threshold with chemo. Now there are not many new chemotherapy drugs being discovered, and you can see that it's only the old chemotherapy drugs being changed into various combinations. So chemo is sort of reached its threshold. I don't think we'll really have more chemotherapy drugs in future, and that's not the way where cancer management will go forward. We discovered biological therapies. Biological therapies, by that we mean we are using monoclonal antibodies and we are trying to target some part of the biology of cancer. Suppose we are targeting the VEGF pathway, we are using bevacizumab, which is an anti-VEGF monoclonal antibody. We also have anti-EGFR monoclonal antibodies we use cetuximab or panitumumab in colon cancer, where we are looking at blocking the EGFR pathway. We also have targeted therapies. Now, targeted therapies, we mean we have identified a target, like in lung cancer, we identify that there is a EGFR mutation, and then we use oral gefitinib, erlotinib, osimertinib. So we are identifying a target and using targeted therapies. And now we say in cancer, as medical oncologists, we always say it is personalized therapy. It is the era of personalization of medicines for cancer patients. It's not that one treatment will be the same for every cancer patient. You will use various testing platforms, and the most important one coming out now is the NGS testing or the next generation sequencing, where we are sequencing the tumor, identifying what are the targets, what is driving the cancer, and then we are blocking these with various targeted drugs or combination of biological drugs with chemotherapy. And this is the way we are moving to more personalized therapy for cancer management. But now the most fascinating part, we are coming to immunotherapy, and immunotherapy is one of the, I will tell you why we are so fascinated with immunotherapy. So 2018, this was the Nobel Prize to Professor James Allison from the US and Dr. Tasaku Honju from Japan. And they got this, and this was rightly deserved for their work on immunotherapy. And let's run through why they did this, why they deserve this, and why this has changed our cancer management. So what is immunotherapy? How does it work? Now, to assess the basic principles, just try to understand how our immune system works. Identify if there's an infection which comes into our body, that's a foreign antigen. How is it eliminated from our body? We have two parts of the immune system. We have the innate immunity and we have the adaptive immunity. Now, as the antigen enters in the blood, immediately the innate immunity comes into action. Those are those granulocytes, the neutrophils, eosinophils, basophils. We have the macrophages, the dendritic cells, the antigen presenting cells, and also the NK cells. Now, these are the ones which immediately grab onto the antigen and try to destroy it. But we know innate immunity can only gives us a rapid response and a short-term response. What gives us a long-term response is the adaptive immunotherapy. Now here what is happening, it's our B cells which are getting stimulated and they are producing the antibodies which are going to last in the body, and the T cells get activated, and these are the activated T cells or the helper T cells, and the CD8 T cells which are the activated T cells kill the antigen, and that's how our immunity works. Now these T cells also have memory, and these kind of can give us a long lasting response against the infection. Now, to understand how the basis of immunotherapy, you need to understand how the T cell latches on to the antigen. And that's very important because that's the principle being used for even cancer immunotherapy. So let me just explain to you, if I have a antigen which comes in the body. Now there's a foreign antigen, this is a yellow thing. It came into the body. What happens immediately? The dendritic cell is the antigen presenting cell. It will catch the antigen and it will show the antigen with the help of what is called the MHC molecule on its surface, and it will show the antigen to the T cell through the T cell receptor. Now, what you need to understand is without the dendritic cell, the antigen cannot be identified by T cells. So this dendritic cell is using a MHC molecule on the surface and it is showing this antigen to the T cell. Now, this binds to the T cell with the T cell receptor. So this is called signal 1. Now, signal 1 is only identification. So the antigen being shown to T cell identifying it, binding it through the T cell receptor, this is signal 1. This cannot activate the T cell, but this is the first identification which happens. After this, what happens is a signal 2 takes place. And in signal 2, what we mean, it is the activating signal, where the CD28 molecule in the T cell binds to the B7 molecule in the dendritic cell. The moment signal 2 takes place, the T cell gets activated and it does its job. Look at these three diagrams. The first diagram on top is what happens. You're seeing there, the antigen presenting cell is showing the antigen through the MHC molecule to the T cell. So the lower one in the first diagram is called signal 1. This is the identification. Now what happens as soon as identification happens? Now signal 2 takes place, and this is known as co-stimulation. Now because the signal 2 is co-stimulatory, the T cells become active, they will start multiplying, they will start doing their job, and they will start killing the antigen. And they will also multiply and produce memory thing. So now, once the job is done, now these T cells have to stop acting. Otherwise, what will happen is these active T cells will start killing everything in the body. You will start having autoimmune reactions in the body. And that is why when the job is done, look at diagram B in the middle. When the job is done, a second signal, which is the inhibitory signal, is created. So what is the inhibitory signal? There is an inhibitory molecule which is expressed on the antigen presenting cell, which binds to the inhibitory receptor on the T cell. Now what this inhibitory signal does, it tells the T cell the job is done, now stop multiplying, stop doing the action, and then the T cells become unresponsive. Now you need to understand, only with signal 1, that is just the antigen recognition, T cells cannot become active in our body. So what you need first the antigen coming in, you need the T cells recognizing it, signal 1 taking place, then You need the signal 2 or the co-stimulation signal happening, that is the activation of T cells, and the T cells are becoming active, multiplying, destroying the antigen. And then you need the co-inhibitory signals starting to work, and that means stop the T cells. The job is done, stop multiplying. And this is how our immune system in our body is continuously working against every antigen, against every infection. This is how our T cells are working. Now, what we have identified now is there are multiple co-stimulatory molecules and there are multiple inhibitory molecules for the T cell. So it is not only one molecule. Now, for the co-stimulatory, the one I showed you was called the CD28, which is expressed on T cells, which binds to the B7 molecules and activates the T cells. There are other molecules like this which have been identified. Some are called CD40 ligands, some are called OX40. Now, among the suppressive molecules, the most important ones, two most important ones which have been discovered, one is called the CTLA4 and the other is called the PD1 or the programmed death 1. Now, what CTLA4 is doing, when it gets expressed on the T cells, it binds to the B7 molecules and shuts off the T cell. What does PD1 do? PD1 binds to the Pdl1 molecule on the antigen presenting cell or the macrophage or the dendritic cell, and it shuts off the T cells. So the T cell stimulation will not happen anymore. So we have now stimulatory molecules, we have inhibitory molecules, and we have identified how they play a part between the T cell and the antigen presenting cell. Now, what happens in cancer? Now, you need to understand in cancer also these cells are antigens. Basically, though they are our own cells, but they have developed mutations, and in many ways they are like foreign cells, and they are multiplying in the body and they are coming out into the bloodstream. So what happens is these antigens are then identified by our T cells or by our antigen presenting cells. Where does this happen? This happens first in the lymph node. So if you follow this, going from 1 to 2, these antigens in the bloodstream are being identified by our dendritic cells. Now, these dendritic cells are then taking these antigens and with the MHC molecule are showing it to the T cell. Now, the T cell is identifying it by signal 1, and then by signal 2, it is activating the T cells. And once the T cells get activated, they start multiplying. Now, these T cells which multiply, step 4, they will go into the area where the tumor is there. They will infiltrate the bloodstream there. They will infiltrate the microenvironment there, and then they will enter the tumor cell and they will destroy the tumor cell. Now, as the tumor cells destroyed, more and more antigens are formed, and this are again being identified. Now, this whole process, this whole circle is called the cancer immunity cycle. And this is a very active process happening in our body round the clock. So what happens? If we have such a strong immune system which is continuously monitoring and killing these cells, why do we develop cancer? Why does anyone develop cancer? Now it is understood that our cancer immunity is there in everyone's body, which is checking the cancer cells. But sometimes the cancer cells are very smart and they avoid the T cell detection and they avoid being killed by T cells. So how do they do that? One, they may sometimes the tumor cell will not express the MHC. So the antigen presenting cell, the MHC is not there, there will be no recognition. If there is no recognition, there is no signal 1, the T cell will not get activated at all. Second, they will have the MHC molecule, the T cell will identify, but the second signal, the co-activating signal, which was supposed to happen with the B7 molecule, does not get activated because the B7 molecule is not expressed by tumor cells. So the co-stimulatory molecule does not get expressed, so the T cell doesn't become active. But third, and what is the most important mechanism we have learned, is these tumor cells become very smart and they increase the expression of inhibitory molecules. And what we have identified, Pdl1 or the programmed death ligand 1 is the inhibitory molecule which gets overexpressed by the tumor cell. Now what it does, though there is a signal 1, there is an identification of the tumor cell by the T lymphocyte. The signal 1 takes place, but the Pdl1 gets overexpressed in the tumor cell. It binds to the PD1 in the T cell. And this is, if you remember, I told you this is a co-inhibitory signal. This inhibits the T cell and it shuts the T cell off. So though there is T cells, there is identification by the antigen presenting cell, but because of overexpression of Pdl1 in the tumor cell, the T cells become inactive and they are not able to activate and kill the tumor cells. This has been identified as one of the most important mechanisms for cancer propagation in the body because of overexpression of inhibitory molecules, and this is what is being capitalized for also treatment of cancer. So how does a body develop cancer? You have part, I explained to you how our immune system, which is the immune surveillance, which is there round the clock, but what cancer cells do, they do an immune escape. And they do an immune escape. The most important part is by increasing the inhibitory molecule expression. And because of that, the T cells become inactive. They cannot fight the cells. So the cancer cells propagate and spread. So this is called immune escape. Now, this is the yin and the yang happening in our body round the clock. And when our immune escape phenomena gets more, cancer develops and propagates in the body. If our immune surveillance remains very high, the cancer is always remain in check and this does not develop into a cancer. So how have we capitalized this information? And this is where the whole concept of immunotherapy or checkpoint inhibitors comes into play. Now look at the right side figure. There you have the T cell and you have the cancer cell. You have the identification which has happened, the signal 1 has happened. Now, what the cancer had done, it had overexpressed the PD1 molecule, the Pdl1 molecule, which had bound to the PD1 in the T cell, and it had caused the inhibition to happen and the T cells were inhibited. Here we have discovery of monoclonal antibodies called checkpoint inhibitors. Now they can be an antibody which may be against the PD1 molecule, or they can be a monoclonal antibody against the Pdl1 molecule. And these are called PD1 or Pdl1 inhibitors, which are actually inhibiting this pathway, this inhibitory PD1 and Pdl1 signaling. And as soon as the monoclonal antibody blocks this pathway, either this side or this side, as the pathway gets blocked, what happens? The T cells are now free and the T cells start multiplying and they start dividing and start killing the cancer cells. So the T cells again become activated T cells against the cancer. And this is the whole concept of development of checkpoint inhibitors or PD1, Pdl1 inhibitors, which is allowing our immune cells to become active again. The left side figure is what happens with CTLA4 inhibitors. Now what we have identified, the T cells and the dendritic cell first identification of the antigen is happening in the lymph node. And there the molecule which is expressed is CTLA4, which binds to the B7 molecule on the antigen presenting cell. Now, the first development of monoclonal antibodies against the checkpoint was against CTLA4, and these were called CTLA4 inhibitors. So what they did, they blocked the CTLA4 antibody. So this inhibitory signaling did not happen in the lymph node. So the T cells became free in the lymph node and these T cells then moved out and started killing the cancer cells. So these are the two drugs. Now you put them into broad groups. We call them CTLA4 inhibitors or PD1, Pdl1 inhibitors. And these are called the checkpoint inhibitors and these are broadly called immunotherapy in cancer management. Where are we now? We have multiple drugs. Let's start from the left. We have two CTLA4 inhibitors. You have Ipilimumab. That's the one which is approved in various cancers. You're seeing its use in melanoma and also recent approvals in renal cell cancer, lung cancer also. We have Tremelimumab. Now, Tremelimumab is not yet approved, but we've seen recent data in hepatocellular carcinoma where there is a likelihood it will come into approval. Then we have the most commonly used checkpoint inhibitors. These are the PD1 inhibitors. We have Nivolumab, we have Pembrolizumab. These two are from different drugs, different companies, but both are kind of blocking the PD1 pathway and they are used extensively. And then we have three Pdl1 inhibitors. We have Atezolizumab, we have Durvalumab, and we have Evolumab. These are all approved in various cancers and we can just talk about them as time goes by. But these are the broad group of drugs. You will classify them into two types. CTLA4 inhibitors, that's acting in the priming mechanism in the lymph node. It is blocking the CTLA and then allowing the T cells to become active. You have Ipilimumab, that's the most important one because already approved in many cancers. And then you have the PD1, Pdl1 inhibitors. Among the PD1 inhibitors, two important drugs, Nivolumab, Pembrolizumab. Among the Pdl1 inhibitors, three important drugs, Atezolizumab, Durvalumab, Evolumab. So why are we so impressed with immunotherapy? So that was how the basis of immune checkpoint inhibitors came into use, how we capitalized our immune system mechanism, how we allowed the T cells to become active by releasing the brakes on the T cell. But why are we so impressed with immunotherapy? Now look at these curves. In an advanced cancer, what happens? You see the left side curve. Eventually, the cancer multiplies. We treat it, we get some response, but eventually the cancer cells become resistant and the patient will eventually die because of the cancer multiplication. Now, when we use chemotherapy, we increase the cell kill, but eventually chemotherapy either loses effect because the cancer cells become resistant to chemo, or chemotherapy causes toxicity and you have to stop the chemotherapy. And eventually, again, you lose response and patients will again die because of the cancer multiplication in stage 4. If you use tyrosine kinase inhibitors, you get initially very good responses. You're moving the curve to the right. You're improving survival. But eventually, they are all developing resistance and the patient dies in stage 4 disease. Now, in immunotherapy, what happens? Because you're stimulating your own immune response, the immunotherapy can have memory. And this is why everyone fancies immunotherapy and all of us are very impressed with immunotherapy. Those patients who respond, you can see the curve later, we reach a plateau. And there are a group of patients who will not progress and they can have a potential to be a cure. So this curve, which is called the tail of the curve, and there is a group of patients on the tail who are surviving for a very long time on immunotherapy, even with advanced stage 4 disease. But the problem is, not everyone responds to immuno. So you keep trying to say, how can we increase the response to immuno? And that's where immunotherapy combinations are coming in, where you're combining immuno either with another immunotherapy drug, or you're combining it with chemotherapy, or you're combining it with some biological drug, trying to increase your response and still trying to get more patients onto the tail of the curve. So the major fascination with immunotherapy is what I would say the durability of response. Those patients who respond can have a very durable, long-lasting response because immunotherapy has memory, and that's what's not possible with chemotherapy in many situations. Of course, there are other advantages which we will discuss about as we go on. So where are we using now checkpoint inhibitors? And this list is getting bigger and bigger. We started with melanoma, renal cell cancer, lung cancer, urinary bladder cancers, head and neck cancers. We, we looked at MMR deficiency cancers, hepatocellular cancers. Now there are gastric cancers, esophageal cancers, cervical cancer, endometrial cancer, skin cancers, in hematological malignancies, lymphomas, especially Hodgkin's lymphomas, and the list is getting more and more every day. Almost every cancer is getting included in this list of where we use immunotherapy, and that's why we say immunotherapy is going to become the most important part of cancer care in the medical point of view as time goes by. Now, what we have understood is immunotherapy does not work for everyone. It works for some patients, but there are a lot of patients where immunotherapy doesn't work. So we need some biomarkers to understand who are the patients where immunotherapy can work. Now, unfortunately, biomarkers are still very rudimentary in development in immunotherapy, but we still have some information at least. So what are the biomarkers we have which we can use in clinical practice? And this is what you will ask for in your patients, and you will keep looking at these reports. You may have look at Pdl1 expression. You have what is called as MMR deficiency or mismatch repair deficiency. And third important one is tumor mutational burden. Now let me just tell you about where each one stands in usage. Pdl1 expression. Now this is a very complicated biomarker. This is not a very straightforward biomarker. It is not the same to say PDL1 of lung is positive or PDL1 of head and neck is positive or PDL1 colon cancer is positive. It is not a uniform biomarker. For us also as medical oncologists, we have to be very clear when we are talking of what is PDL1. So the questions we always ask, if someone tells us PDL1 is positive, the first question we ask is, what was the antibody they used? What is the clone of the antibody they used? What was the platform they used? And this is because there are different kinds of platforms being used for PDL1 testing. We have the DACO platform, which is called the 22C3 is the antibody, and then there's another antibody called the 28-8 antibody. We have the Ventana platforms where we use different antibodies called SP263 and SP142. Now, it is for us as medical oncologists, it becomes very important when someone tells us PDL1, which platform was used, which antibody was used. The second thing is, even PDL1 is not a uniform reporting, just saying PDL1 positive. One needs to understand what is the type of PDL1 being expressed. When we look at PDL1 expressed only on tumor cells, then we are looking at the TPS or the tumor proportion score, where you're looking at PDL1 positive tumor cells versus the other cells. versus negative tumor cells, and you're giving a percentage. Now, this is what we do where in lung cancer. In lung cancer, we always say we did a score, we said the TPS is 1%, 10%, 50%. But in many other cancers, you don't use only tumor proportion score. You use what is called as combined proportion score or CPS. In CPS, what are you doing? You're looking at tumor cells which are positive for PDL1, but you're also looking at all the immune cells which are positive for PDL1. That could be the lymphocytes, that could be the macrophages, and then you are creating a score by dividing them with all the tumor cells into 100. And that is the combined proportion score. Now, where are we using combined proportion score? In breast cancer, in stomach cancer, in esophageal cancers where the approvals are there. These are all using CPS. Even in head and neck cancer where we have started using uh, PDL1 for higher response prediction, it is a combined proportion score. So very important, when you see a PDL1 report, just look at two things. Look at what is the antibody they used. It will be mentioned this has been done by the 22C3 platform, or it is what is most commonly used in India is the SP263 platform. So it will be written by, it will be done by this test. And second, what is the reporting? Is it a TPS or is it a CPS? And most important, in many cancers, it is going to be CPS. Only in lung cancer is where TPS is important. Now, there are many cancers where PDL1 has no relevance to play. Renal cell cancer, we use immunotherapy extensively, but PDL1 has no predictability. So we do not do PDL1 testing in renal cancer. We do not do PDL1 in melanomas. We don't do PDL1 testing in hepatocellular cancers. Bladder cancers doesn't have much approval on PDL1. So what we see is PDL1 is not a uniform biomarker. You cannot extrapolate saying, I did a biopsy in any cancer and I did a PDL1, it's positive, so immunotherapy will work. It is not such a straightforward line. What we need to see is the cancers where we are doing it, what is the approval? Has PDL1 relevance in those cancers? And then use that information. Now, if you see breast cancer, triple negative metastatic breast cancer, PDL1 is done using the SP142 platform where you look at tumor cells and immune cells. And what is positive there is immune cells. The immune cell has to be positive. The tumor cell may be positive, may not be positive. So in breast cancer, we use SP142 in triple negatives and say immune cell positivity is positivity for us, for PDL1. So very important, PDL1 expression is probably the only biomarker which we have for general use in the maximum wide cancers, but it is always a very complicated biomarker. So it is not only a PDL1 expression which defines response to immunotherapy. The second important biomarker is mismatch repair deficiency or MMR deficiency, or you can also call these MSI high tumors or microsatellite high instability high tumors. Now, this is a very good biomarker for response to immunotherapy. It is very predictive for response. It is very easy to do. This is very easy because you can just take the tumor biopsy samples, ask for an IHC for MMR. What they will do is they will run the 4 antibodies, and with that they will tell you whether the IHC is MMR proficient or MMR deficient. Now, if any one of those antibodies is in the IHC is not expressed, it is called MMR deficient. And we know MMR deficiency is the state where they can respond very well to immunotherapy. If you do it by PCR and you run a PCR and you do the MSI testing, then you can say they are MSI high or MSI unstable, or they are MSI low or MSI stable. Now, mark you, there's a lot of confusion which gets created because of expression of how people use it. Someone would do a IHC test and then say, I have a MSI high tumor. Now, they are the same meaning, but please try to use the correct expression. If you are doing an IHC test, you are looking for the mismatch repair genes by IHC expression. So please report this saying, I have a tumor which is MMR deficient. Now, if you are running a PCR test, then I saw they are MSI high. So then say they are MSI high. Don't run a PCR test and then say they are MMR deficient, or don't do IHC and say they are MSI high. We know they mean the same thing, but if you have said they are MMR deficient, I know you have looked at the IHC. Or if you said MSI high, I know you have looked at PCR. Now, for us, what is important? MMR deficient tumors or MSI high tumors, they are the same expression. They are the same thing you're talking about. And these I know will respond very well to immunotherapy. But unfortunately, they are very rare to find. In the metastatic setting, when you start doing blindly MMR testing, you will get only 5% of patients who are MSI high or MMR deficient. So these are the only patients, 5% of patients who will show response to immunotherapy. The rest may not show a response. Now, where are the cancers where they are very prominently there and where we should specifically look for them? The first one is endometrium. When you have metastatic endometrium, this is a very high chance they will be MMR deficient. So look for it there. Colon cancer is the next one. If you have metastatic colon cancer now, especially the right side colon cancer metastatic disease, MMR deficiency will be high. That's where we look for it. But you can look for it in various metastatic settings in stomach, in gallbladder. And now because we have a pan approval for immunotherapy, nowadays for every cancer which progresses when you don't have options, we say just do the MMR test. You never know, you may hit a rare percentage where they may be MMR deficient. Even a breast cancer may be MMR deficient. Even rarely an ovarian cancer will be an MMR deficient. So that's the reason MMR is a very broadly used marker. Very simple to do. Look at the expression of MMR by HC. PCR is a little bit more complicated because you need to send it out, but IHC can be done anywhere in any local labs, and that can help you guide choosing immunotherapy. Now, why we like this is because they respond extremely well to immunotherapy and they can have long sustained responses. The third biomarker is tumor mutational burden. What you're doing is you're looking at how many mutations are there in the tumor, and this is being reported as that much mutational burden per megabase. Now, this is also a very difficult marker for clinical use. It requires a NGS testing, and it is said the broader the NGS panel, the better it is because you have to look at a lot of genes to understand how the mutational burden is. The other issue is there have been various cutoffs. We don't know what is the right cutoff. The one which we use commonly is more than 10 megabase. This is kind of the one which gets reported by various labs saying more greater than 10 is high tumor mutational burden. Now, FDA has approved TMB for in all solid cancers which have exhausted the standard therapies. So if you have any of these solid cancers where you treated them with all standard lines of treatment and chemotherapy and completed all the therapies, when you have nothing to offer, if you did a TMB and you found a high TMB, you can still offer them immunotherapy with pembrolizumab. That's where FDA has approved it for use. But what we are understanding much more, there are cancers where with very high TMB, the chance of response can be very good. But also there are cancers with low TMB where response can be very good to immunotherapy. That's why we say TMB is a difficult marker for clinical usage. Yes, but a very high TMB always for us is predicting there will be a higher response. It just means a low TMB does not mean immunotherapy will not work. So we have to be careful how we use these biomarkers. But as of now, we have these three biomarkers in clinical usage. And this is what we do for most of our patients. There are a lot of experimental biomarkers going on. We look at sometimes T effector cells. We are looking at clinically NLR ratio, neutrocyte to lymphocyte ratio. But again, these are not established for all cancer usage. These are the only three which are established. So I've told you about immunotherapy. What are the limitations of immunotherapy? Again, some patients can respond dramatically. Long-term responses can happen, but there are some patients who will never respond to immunotherapy. There is a major segment who will not respond to immunotherapy many a times. I've shown you the biomarkers information. There is no good biomarker to predict who would respond. There is only these three biomarkers for clinical use, and then apart from that, we do not have much in biomarker space. And the third important part of immunotherapy is immune-related adverse events can happen. Though it can happen in few patients, one needs to understand what are immune-related adverse events. So moving on to IRAEs, these are called. Now, why does it happen? What happens is our T cells are active now because you have unblocked the T cells by giving the immunotherapy. So now these T cells can act against our own body and they can cause an immune reaction. This is just like our autoimmune diseases. Our autoimmune diseases is our own T cells acting against any body part. And this can happen in any organ of the body. The most commonly you will see skin related, but it can happen in colon, liver, lung. One of the most common is the endocrinology effects, especially to the thyroid. The most common effect you see is hypothyroidism, which happens once you start treatment with immunotherapy. After a couple of months, you will see the TSH will go up, patients will become hypothyroid, and they need replacement with the with thyroid hormones. But rarely they can be very serious and they can be fatal. Especially we say some of them like pneumonitis, if not identified and not treated well, can become fatal. Colitis can become fatal sometimes. Hepatitis, if it happens, can become fatal. So these are things that you need to know and we're lucky that it happens to a very small percentage. The serious ones are not very common at all. Now, this is a diagram which we show saying that every organ of the body can have an itis. So be aware of it. When we treat immunotherapy, any inflammatory response happening in any organ, it could be related to the immunotherapy drug. So identify it very quickly and then treat it. If I look at what is the incidence, PD1, PDL1 inhibitors, 50 to 60% will have a grade 1 to 2 IRAE. But these are very mild IRAEs, so we never worry about them. We worry about the grade 3 and above IRAEs, but they occur only in about 8 to 10%. In recent literature, we have seen usually most of the cancers, it is about 5 to 8% of patients will have a severe grade 3 IRA. But otherwise, it is in the low grade IRA. But whenever you add the CTLA4 inhibitor ipilimumab, the immune-related adverse events are much higher. So if CTLA4 unblocks the immune system much more, and these can cause severe grade 3 to 4 IRAs in about 50 to 27% of patients. And even in the earlier literature, we had seen they could be fatal if we had not identified them. When do they happen? They usually will happen early. Most IRAs happen in the first few months of treatment. In the first 2-3 months, they will happen. Most patients in the long term will not have IRAs. So actually, after your patient gets set onto the immunotherapy after 3-4 long-term side effects, but most will not have major side effects in the long run. How do we manage an IRA? We follow the same grading system, and our main essence is steroids have to be started if they are grade 2 or grade 3 onward. So we have to be very vigilant. The moment we see an IRA like colitis, then we have to start them on methylprednisolone or or prednisolone, depending on our clinical situation. And these are patients where we may also require consult from all our colleagues from various departments. We may require from our endocrinologist, we require from our gastroenterologist if we develop colitis or hepatitis. We require a pulmonologist on board if it's pneumonitis. So that's why we say it's a very multidisciplinary approach. When you give immunotherapy, be very vigilant, have a whole team there to understand if it is a severe IRA, manage it aggressively so that you can pull your patient out. Rarely patients will require more than steroids, second line, third line therapy, which are various uh, immune modulators, like we can use cyclosporin or tacrolimus or MMF. But again, luckily for us, the usage is very less of these drugs. The requirement is very less. One thing about immunotherapy, it is not like chemo where you say, if you have a side effect, let's reduce the dose. It is not recommended to reduce the dose of immuno. There is fixed dose or there is dose according to the weight of the patient. We stick to what is the standard dose. Now let me quickly run through data in various cancers. It's impossible to cover all the cancers, but I'll just talk about common cancers in the data sets. So this is a very interesting field which is changing. Renal cell cancer. Now clear cell renal cell cancer stage 4, all of you know, till a few years ago, first line treatment was either sunitinib or pazopanib, and that is the way we treated our patients. But now the first line therapy is always immunotherapy. Now it could be an immunotherapy in combination with immunotherapy. That's the top left one. This is called IO. Ipilimumab, nivolumab is first line treatment. Or it could be what is you're seeing in the other remaining 3 data sets, where you're combining immunotherapy with a tyrosine kinase inhibitor. You're combining pembrolizumab with axitinib, or you're combining nivolumab with cabozantinib, or pembrolizumab with lenvatinib. And all of them have been shown superior to sunitinib. So renal cell cancer, first line data is immunotherapy combination, IO or IOTKI. That's the way we say it. And they have clearly better survival than sunitinib alone. Now look at lung cancer. In lung cancer, we used to say 5 years survival of metastatic lung cancer is less than 5%. And that's the reality, and that's what we had seen all in practice for many years. Now this is using immunotherapy with pembrolizumab in first line treatment and not using chemotherapy at all. Only pembrolizumab in patients who have high Pdl1 expression greater than 50%. What we are seeing at 5 years, 30% of patients are alive. Can you imagine that? This is with immunotherapy where you used immunotherapy as first line. Now, if you look at the comparator arm, even with chemotherapy, about 16% of patients are alive. This is better than the 5% I spoke to you about, but this is because many patients who progressed on chemo got immunotherapy as second line. So what we have done, we have this poor survival malignancy stage 4, where you're getting now 30% alive at 5 years if their PDL1 was strong positive. So for us, we do PDL1 in lung. If we find it strong positive, if no target mutation, we offer them immunotherapy, even as single agent. Now look at adenocarcinoma. If you had PDL1, which is less than 1%, or 1 to 49%, or more than 50%, immunotherapy especially this trial did pembrolizumab in combination with chemotherapy versus chemotherapy alone. Again, all the patients in the blue are doing better. Your survival of patients with immuno plus chemo is better than chemotherapy. So for us in lung cancer, standard of care, first line, we just look for target mutation. If we don't find a target mutation, we offer immunotherapy in combination with chemotherapy, especially pembrolizumab plus chemo is the first line therapy for this group of patients. It has long-term survival, which is better than chemotherapy alone. What do we do in squamous cell carcinomas? Again, here we are using pembrolizumab in combination with chemotherapy. The only thing difference is the chemotherapy is changed, but again, their survival is better than chemotherapy. And it does not matter whether the PDL1 is more than 50% or even if the PDL1 is 0%. Immunochemo is better in all the three arms, in all the three subsets, irrespective of PDL1. So that's why in lung cancer squamous cell, immuno plus chemo is our first line therapy and not chemo alone if patients can afford it. Now look at breast cancer. In breast cancer metastatic, triple negative breast cancer is the space where immunotherapy is approved. Immunotherapy has no role to play as of now in ER positive or HER2 positive breast cancer. In the metastatic triple negative breast cancer, this was a trial which compared atezolizumab plus nab-paclitaxel versus nab-paclitaxel alone in triple negatives. And what they saw was not everyone benefited. The benefit was only seen in the right side if you see the blue lines, which are combination of atezolizumab plus nab-paclitaxel in PDL1 positive patients. While if you look at the last red line, those are the chemo alone arms in PDL1 positive. Now in the PDL1 negative population, the middle two lines, the red and blue, light blue lines, what they show, if your PDL1 is negative, there is actually no benefit of adding atezolizumab. So what we are learning, atezo plus chemo in triple negatives metastatic setting, one needs a PDL1 positivity. Secondly, here the PDL1 positivity for this trial was using SP142 clone and it was the immune cell positivity. IC positivity was positive. But what we have seen, we get more than 10 months overall survival advantage. And that's why in triple negatives nowadays, we do a PDL1 testing, we check it out, and if they are metastatic at first line, we offer them immuno plus chemo rather than chemo alone. Now, in colon cancer, now this is a place where there is very limited data of using immunotherapy because colon cancers don't respond very well to immunotherapy. It is only that small 5% of patients who are MMR deficient colon cancers which show very good response to immunotherapy. And this was a trial which compared single agent immunotherapy with pembrolizumab as first line therapy in comparison to chemotherapy in metastatic colon cancer with MMR deficiency. Now, what they saw, there's a clear improvement in progression-free survival when you're using uh, pembrolizumab as a single agent instead of chemotherapy. And doubling of PFS was seen. And even the overall survival numerically was much higher, though it didn't meet statistical significance. But if you look at the curves, clearly the immuno patients are doing better in the longer run than patients with chemotherapy. So in colon cancer, if patients are MMR deficient, even in the first line metastatic setting, we can use immunotherapy as first line. But otherwise, we do MMR deficiency and use it in the second line or third line settings for our metastatic patients. Head and neck cancers. Now, this is again advanced head and neck cancer, either metastatic or those which have incurable, which are advanced disease. This was using immunotherapy with pembrolizumab, either alone or in combination with chemotherapy with platin 5-FU, comparing them with what is the standard of care. And the standard of care is platin 5-FU cetuximab. That was the standard of care till a couple of years back. So what this showed, if you looked at PDL1 CPS positive, if it's greater than 20% and greater than 1%, then even single agent pembrolizumab had a better overall survival than patients with getting chemotherapy plus cetuximab. But yes, if the CPS was lower than 1, it was not better than using the chemo combination with cetuximab. But when you combine chemotherapy with immunotherapy in first line setting in head and neck cancers, in all patient subgroups, this combination is better than using chemocetuximab, whether the CPS is low, whether CPS is greater than 1 or CPS is greater than 20. Even the intent to treat population was better, and that's why FDA has approved pembrolizumab plus platinum 5-FU combination for head and neck cancers as first line setting treatment for metastatic disease. What is the real world experience? I will kind of just quickly in the last 5 minutes or so just show you some of our data sets to understand why we are fascinated with immunotherapy. This is our patient, one of our first patients, 2015, renal cell carcinoma, metastatic disease, got sunitinib. After 3 months of sunitinib, he progressed, and this was how the disease was growing extensively all over the peritoneum. He had metastasis in liver, he had ascites, his general condition was very poor, and then he got immunotherapy with nivolumab. Just 3 doses of nivolumab we gave him in April 2016 to June 2016, and we did a scan after that. Mark you, 2016 was when immunotherapy came in India for the first time. It was not approved till October 2016, so we had to import the drug and give it to him at that time. But if you see the response in 4 months, in just 3 doses, that's 2 months, the tumor had disappeared completely. We could not even believe it because this is like a lymphoma melting away, and renal cell cancers don't melt away like this. Now, this patient got 1 year of nivolumab till June 2017. And then we kept doing serial PET scans, all were negative. We stopped treatment. Now, the international guidelines say you treat for either 2 years or you treat indefinitely. This is not what we do in our current setting because of cost constraints. We eventually keep watching patients if closely. If their scans remain normal, we try to stop at some time or the other in most patients. This patient we stopped after 1 year nivolumab. And if you look at it, 5 years down the line, even now in Jan 2022, he continues to be in complete remission. And this is what I was telling you. Advanced RCC, stage 4, which progressed on sunitinib, survival is usually 3 to 6 months, sometimes a year with various therapies. But this patient is now 5 years down the line. He's off treatment. This is because immunotherapy can give you durable responses with memory. And this is the whole fascination of immunotherapy. We could never stop patients on TKIs. We used to keep them on indefinite TKIs till the end. But here we are stopping treatment and still seeing persisting response. This is a 76-year-old male, lung cancer, squamous cell stage 4. Look at the left side lung, how bad it is. Now this patient gets immunotherapy. He got nivolumab and he got 8 doses. Look at the scan now. The left lung mass, it has completely disappeared. Now the fascination, we stopped after 1 year. From 2019, he's off therapy. Even now, 3 years down the line, he continues to be in complete remission. Now, this is again something we had not seen earlier in lung cancer. We used to stop chemo. Patients used to do well for a certain amount of months, and then they again used to progress. And that's why we kept saying repeated different therapies are always required in lung cancer. Patient got only immuno, 3-4 years down the line, continues to remission, normal life. Here's a 55-year-old with colon cancer, with lung metastasis. He got chemotherapy, he progressed. Now that was 2018. We did the MMR, we found it is MMR deficient. So we offered him immunotherapy, single agent immunotherapy. And when we gave him, after a few months, we saw this is how the scan is. The mass has become completely necrotic. There's a small tissue left there. We treated him till 2019. And then even this patient, we stopped treatment. Even now in 2022, he continues to be in complete remission. So this is again sustained response in MMR deficient patients. And this is what I keep trying to say. If your patient responds to immuno, it can have a sustained response. Now, not all patients are going to respond. That's a major limitation, but there are a group of patients who will do well. This was one of our studies where we looked at a large population of MMR deficient cancers. We had 80 colon cancers. We looked at 54 stomach, 32 endometrium. But out of these, we only found positivity rate very small. 4 MMR deficients out of the 80 colons we saw, 6 in stomach. We had 7 in endometrium. But when we treated these patients of MR deficiency, irrespective of the cancer, we saw a very good response and a sustained response. And this is why MMR deficiency is important. We have also looked at combining immuno and targeted therapies in renal cell cancer and seen that same sustained long-term response. So that's why in renal cell cancer, we are very emphatic when we tell our patient, first-line immuno combination is the way forward. It may be IO-IO or it may be IO-TKI. So last slide, what are the advances happening? How is the space changing? Now we are moving, this was all data which you saw, which came out in the metastatic setting. And in the metastatic setting, it came out from third line data, then second line data, and it strongly has become first line immunotherapy in most cancers. But now we are moving to an era where adjuvant therapy with immunotherapy is coming into role. If you look at melanoma, it is approved as adjuvant pembrolizumab is approved. If you look at lung cancer now, we have seen recent data of adjuvant atezolizumab being there as a positive data set. Renal cell cancer, we have nivolumab approved, pembrolizumab approved as adjuvant immunotherapy for 1 year. In urinary bladder cancer, we have Nivolumab after surgery approved as 1 year of treatment. So we are now seeing this going into the adjuvant space. And recently, one of the most interesting spaces is the neoadjuvant setting. In breast cancer in triple negatives, pembrolizumab is approved irrespective of Pdl1 for patients who have high burden disease in the neoadjuvant setting in combination with chemotherapy. So if you do a AC taxane regime, you add pembrolizumab to that and then you operate. What they saw, they get higher PATH CRs, higher disease-free survival. Now, we do not have overall survival data yet because these are adjuvant data and neoadjuvant data sets which will take a long time, but it is already approved for clinical use. We have recently seen lung cancer data, operable lung cancer, giving neoadjuvant immunotherapy in combination with chemotherapy, nivolumab with chemo, having a much higher PAT-CR. So that's where now the setting is going into. So it's getting into a very interesting space, and I think the future is going to be more and more early usage of immunotherapy because you keep hoping you're going to get a potential to cure many patients. So this is my conclusion. Immunotherapy treatment has become very important in cancer care. It is either as a single agent or as a combination, but immunotherapy is here to stay. The potential for long-term cure is what has fascinates us. We have seen that in the metastatic setting, and it's being moved forward because you can get probably cure a larger group of patients. Side effects, I told you, are rare. They are not very common. When we talk of side effects to immunotherapy in comparison to chemotherapy, we don't bother too much. We tell them the side effects are not at all like chemo. There's no hair loss, no vomiting, no severe fatigue, though there can be a specific immune related side effects which we need to understand, explain about, and as clinicians we need to catch it early so that we can treat them with steroids and correct it as soon as possible. And the fascination again, it's a single drug. It's a single type of drug, guys. It could be a PD-1 inhibitor, Pdl1 inhibitor, but look at the extensive use. It is being used in almost all cancers. It works in a wide variety of cancers. And the reason is it's not working on the cancer per se, it's working on our own immune system, and our own immune system is eventually fighting the cancer. So usage of these in various settings has come up and is being approved because of this wide variety of cancer usage data sets. So with this, I would like to conclude. Thank you very much. Thank you. So questions? So there's a question here about abscopal effect with immunotherapy, especially with Nivolumab being reported. Is there effect seen with PD-1 and other immunotherapy drugs? Now, a good question. What is abscopal effect? If you treat with suppose you're giving you have a patient with metastatic disease. There's a primary in one area, and there's metastasis in the lungs. Now you radiated patient, you treated with immuno, and you radiated also a primary. And what you see is sometimes because of giving immunotherapy, you're having an abscopal effect, and the metastatic sites are also getting response. So it is an effect which is different, which is very difficult to explain, but this is an immune related effect. So in radiation, we should talk, does radiation have abscopal effects in various situations? There's a lot of thought about SRT having abscopal effects in cancers. When you treat a primary and you may have an abscopal effect, what has been seen is with immunotherapy and radiation combination, there may actually be abscopal effects. So that's the reason why this has been an interesting talk always, but we have never proven it. So we don't really rely on it. We keep thinking, yes, there may be an abscopal effect with immunotherapy, but again, I wouldn't say that this is something that you can say will happen. So it's an interesting phenomena, I would say. Nivolumab in adjuvant setting of esophageal cancer. Yes. So in esophageal cancer, if you think of what is the standard of care, if you're looking at esophageal cancer, what are you doing? You're doing CTRT, you're using the cross protocol, and then you're operating your patients. That's the standard treatment which many centers follow. So if you do a cross and you follow up and did surgery, if you have a group of patients who got PAT-CR, you know they're going to do well. So those are patients we leave, we don't do anything. But those patients who did not get a pathological CR post-surgery, they are all offered 1 year of Nivolumab, and that has shown an improved improved disease-free survival. We again don't have overall survival data for that arm, but the disease-free survival is better for this group of patients. So it is approved in the esophageal space. So Nivolumab, where would you use it in esophageal cancer in the adjuvant setting? patients who received cross, went to surgery, and did not achieve a patch CR. They are the high-risk patients. 1 year of Nivolumab is approved for usage. Can you repeat the MSI reporting by PCR? So remember, when you do MSI testing, it means automatically you're doing a PCR-based testing, or it could even be an NGS-based testing, but you're doing a PCR most commonly what we do. When you look at the number of macrosatellite repeats, you repeat them as MSI high if they are more than 2 repeats. So your report will come as MSI high or MSI stable or MSI low. Now, MSI high is the patients who will respond well to immunotherapy, and they are the same patients which you report as MMR deficient when you do an IHC. So remember the terminology. MSI high is equal to MMR deficient. MSI low is equal to MMR proficient. So if you do an IHC, see the report whether it is MMR proficient or MMR deficient. Please use the same terminologies. That's the only thing I was trying to say. And MSI high patients or MMR deficient patients, offer them immunotherapy in the metastatic setting in any line. I would say the earlier the line, the better, but offer them in any line. It may be second line, it may be third line, because they have a potential for long-term response. Is there any significance of routine investigations, even in R0 resections, for probable role of immunotherapy? So this is coming to the adjuvant data sets. Basically, you've done an R0 and you're looking at adjuvant settings. I wish there was a better way of choosing adjuvant therapy, and now you are getting new biomarkers for immunotherapy. For adjuvant therapy itself, now we are looking at CTCs, we are looking at circulating tumor DNA, and now there are tests available. They are still getting validated in clinical trials, but there are tests available which can actually tell, after surgery you looked at CTCs or selfie tumor DNA, whether you found it or not, and whether this patient will benefit to adjuvant or no adjuvant. But as of now, for clinical usage, we do not use it. So even in R0, we do not have any routine investigations. What we are saying is, if you got an R0 in certain cancers, especially now you're talking of lung cancer, you're talking of melanomas, you're talking of urinary bladder cancers, renal cell cancers. These are the 4 cancers where adjuvant immunotherapy is now approved. So you did R0, you can offer them immunotherapy. In melanoma, it is very strongly advocated. The other indications are very new now for clinical use. So one question is, how many percentage of patients usually respond to immunotherapy, and logistics in India to treat patients? So this is a very important question for our Indian setting, because immunotherapy is very expensive and it is not covered by many by any government agencies and many insurance agencies also. So immunotherapy becomes a very expensive package for our patients. So this is, yes, a very important question for India. Now, one needs to, here it comes into a difference of what cancer you're treating and what are the responses. Now, there are many cancers where the responses are very small. Now, you look at immunotherapy alone in hepatocellular carcinomas, the response rates are only 10 to 15%. So for an HCC, would I offer immunotherapy first line single agent? I say no, that's not where I would offer it. Though now we offer immunotherapy in combination with bevacizumab, because that gives us higher response. The higher response rate goes higher than 35%, and you're getting longer response. So that's how we look at it. But there are certain cancers where the response rates are extremely high. In renal cell cancer metastatic setting, what sunitinib used to do was give us a response rate of about 10 to 15%, 20%, 25%. What does pembrolizumab, lenvatinib first line give us response rate of 70%, and long disease-free PFS and long OS. So that's why I say look at your cancer. Each cancer, see the response rates, what they are, and balance that decision according to what responses are, what the patient can afford. So always remember, immunotherapy will not work for all cancers. It is up to us as clinicians to balance which patient can afford and which patient can get the best response. Now, a lot of times immunotherapy is used desperately in the late line settings as a last setting. Probably that should not be done blindly. That's something that we should not do in India, because that can be a very expensive option. And again, that logistically will not help many patients. So one needs to understand in various cancers, what is the response? This is very variable. How are we improving the response by using combinations, and how to give long-term treatment? So that's one thing I keep telling my students is, though we learn immunotherapy from the West, what we should do is learn how to use immunotherapy for our patients. We don't do indefinite immunotherapy like the West does. We cannot sustain it in our Indian practice. We always say if you had good response, stable disease, long long-term complete response, try to stop the immunotherapy at some time. There can be a group of patients like the photos I showed you. These are patients where we stopped immunotherapy. We did not continue immunotherapy indefinitely. So we are cutting down cost. Another question is rationale of combining anti-VEGF and immunotherapy. Yes, a very good question, because this is where the field is going to. What we have understood, what is VEGF doing? VEGF is immunosuppressant. So when you are the VEGF which is overexpressed in cancers, it suppresses our dendritic cells and our antigen presenting cells. It also changes the microenvironment, so our T cells are not able to enter the tumor environment. So when you combine an anti-VEGF to immunotherapy, it overexpresses our dendritic or antigen presenting cells. Second, it changes the microenvironment, so the vessels become more permeable and our T cells are able to enter the tumor environment. So this was the rationale of combining anti-VEGF and immunotherapy. Now, where is it in clinical usage? In renal cell cancers, when you're using immunotherapy with combination with either VEGF TKIs, you're using axitinib, lenvatinib, cabozantinib as first-line combination, you are rationalizing on this combination. Secondly, in hepatocellular carcinoma, what is the best first-line treatment now for HCC? Metastatic HCC, the first treatment now approved. Earlier we used to say sorafenib, then lenvatinib, but now we say bevacizumab in combination with immunotherapy with atezolizumab. It has shown the most longest survival. So now first line in our HCC metastatic is atezo plus bevacizumab, and it is using the same rationale which I mentioned, combination of anti-VEGF and immuno in this manner. There's a question for immunotherapy in ovarian cancer. So ovarian cancer has been a major disappointment for immunotherapy. So I always say two cancers where immunotherapy has not stood up the test of time. One is ovarian cancer. Second is colon cancer, the routine metastatic colon cancer where the MMR is normal, MMR is proficient. Now in ovarian cancer, all the data sets said that if you combine immuno to chemo, you still don't get that response which you wanted. And that's why patients still with chemo are doing better. Recently, there's a data set where they combined immunotherapy with chemo and bevacizumab, hoping that anti-VEGF will increase the response. Because in ovary, we know chemo plus bev is a standard treatment for many group of patients in advanced setting. Now, even in those patients, adding immunotherapy in ovary did not help. So that's why ovarian cancer, I would say, don't give immunotherapy to ovarian cancer patients, even in the advanced setting. That's the place where you have to integrate PARP inhibitors somehow or the other. And they are looking at even PARP and immuno combinations, apart from anti-VEGF and immuno combinations. But as of now, ovarian cancer immunotherapy doesn't have much role to play. So childhood malignancies and immunotherapy. This is a little bit of a different space. We still don't have good data sets of immunotherapy used in childhood malignancies. Unfortunately, most of the childhood malignancies are the ones which we talk of neuroblastomas, we talk of Ewing sarcomas, we are talking of leukemias, we're talking of brain tumors, and most of these patients don't respond well to immunotherapy. So as of now, the current checkpoint inhibitors are not really very useful for our childhood malignancies. There's a question of combination of anti-VEGF to immunotherapy again. I did explain to you, so that's the same thing. Okay, so there's a question on toxicity. Immunotherapy, if it leads to autoimmune disease, what is the further treatment modality? Now, so this is very important in clinical practice. One needs to look at what is the autoimmune disease which has happened. So immune-related adverse events will happen, and one needs to watch carefully. Now, the common ones are the endocrinology ones. The hypothyroid is the most common. These are very simple to manage. You put the patients on thyroid tablets and thyroid replacement. But only thing is we have to tell our patient this is going to be long-term usage. This is not short-term usage. Similarly, there may be patients who may become diabetic because the sugars will go up and they can be become long-term, lifelong diabetic. So this is things we have to be very careful about. Now, but most endocrine abnormalities can be managed and continued. But if you have some skin-related disorders, usually with steroid creams, they can be managed and patients can continue treatment. But yes, if you develop lung-related pneumonitis, these are patients where you don't want to challenge them again with immunotherapy. You try to give them steroids or second-line treatment, and then you don't usually challenge immunotherapy for that group of patients. Again, colitis is one of those situations where you need to be very careful. Hepatitis is one thing where you need to be careful. So these are these are situations where patients may require steroids for some time, and then you slowly taper the steroids, and many patients will become off steroids. There have been people who have been rechallenged, but there are some situations you balance the disease according to the side effect. If there's a very rapidly growing disease where you don't have options, you may rechallenge, but there are many situations where we don't rechallenge immunotherapy in severe side effects. So one more thing about autoimmune disease, remember transplant patients, we don't usually offer immunotherapy because if you have a patient who's had a liver transplant, you know if I give them immunotherapy, they may develop a rejection of the organ and that can become life-threatening. So these are patients you would not offer immunotherapy. The only transplant patients where we may offer immuno is if they have had a renal transplant. Those are patients, if you have a life-threatening cancer, no other chemo option, I may offer immunotherapy because I know those patients can then end up, if they reject the kidney, they can still end up with dialysis, but it's still life-saving. But yes, other organ transplants, I would say do not use immunotherapy. So be very careful. Especially this question will come because you will see more and more hepatocellular cancer patients, and there are some of them who have been transplanted in the past. We ourselves have patients who have transplanted, developed progressive disease, who have come to us saying, would you offer us immunotherapy? But I say no, for liver transplant, don't offer immunotherapy. You may reject it and it may be life-threatening. So we give PD-1 anti-PD-L1 without doing PD-L1 testing. So yes, you have to understand PD-L1, as I told you, is it's not a very straightforward biomarker. You remember which is the cancer and then see what is the setting. And in some cancers, you are allowed to give it without PD-1 testing. Renal cell cancer, melanoma, you don't need to bother about PD-1, PD-L1 testing. If you're doing treatment in head and neck cancers and you're using combinations, you don't need to bother. If you're doing chemo plus immunotherapy in lung cancer, we don't need to do PD-L1 testing. But if I'm offering my triple negative breast cancer as first line immunotherapy, I absolutely need PD-L1 testing in the metastatic setting. I need PD-L1 positivity. Either we do a IC score greater than 1 or we do a CPS greater than 10, and only then we offer the immunotherapy. Otherwise, we do not offer immunotherapy to PD-L1 negative, triple negative metastatic breast cancer. Now, the problem with this space is you need to understand there's even the difference is slightly in triple negative breast cancer. If I have a metastatic disease, and a neoadjuvant curative disease, the approvals are different. For a neoadjuvant triple negative breast cancer, when I'm combining pembrolizumab to chemo, I do not need a PDL1 test. There we saw the response was equally good even in PDL1 positive and negative patient. So PDL1, mark you, a complicated biomarker. It is important to understand which cancer you're treating, which platform you're testing, which setting you are treating that cancer in, and then choose your PDL1 test. Anaplastic carcinoma in thyroid, any role? Unfortunately, no. Anaplastic carcinomas still are very difficult cancers to treat. I think the treatment for choice is do an NGS, look for BRAF mutations. If you have BRAF mutations, a BRAF inhibitor using a combination of vemurafenib or dabrafenib, trametinib may be the way to go further. So anaplastic carcinomas, no role of immunotherapy, only NGS, look for BRAF mutations. In clinical practice, do we see resistance to immunotherapy? Some patients do progress after some response. Yes, unfortunately, this is the reality. Again, though we keep saying durable response, we show good responses also. There are many patients who will not have sustained response. Look at HCC data. If you see HCC, you've seen better responses. You're seeing 19 months overall survival, which is better than 12 months from sorafenib. But eventually, all of these patients, most of them are progressing and again dying due to the cancer. So immunotherapy does develop resistance also due to various immune phenomena again. And that's the reason why you're trying to combine to try to see can we increase response. So yes, it is not that everyone will have a durable response. It's a small segment who will have the long durable response. Why only TPS was used in lung cancer for PDL1? So PDL1, as I told you, earlier the thought was if tumors are high PDL1 only, then the negative feedback is happening, the negative suppression is happening. So maybe that was most important. But when we later learned, even the tumor cells and the macrophages and the lymphocytes express PDL1. So immune cells are also important. So this is a very confusing field. Which platform, which testing is changing very rapidly, and that's the reason why you just need to understand that whole thing. It is not one test for everyone. Why all checkmate and keynote trials have DFS or PFS as the primary endpoint and not overall survival. No, I wouldn't agree with this. So not if you remember, the DFS PFS is used as a checkpoint, as an endpoint, just to get your earlier data sets clear. You get an earlier response to your trial. So that's the reason why everyone in cancer used to use DFS PFS. But in immunotherapy, remember, there are many cancers where the PFS is not better. So let me tell you, lung cancer, second line setting, if you're looking at patients who progress on chemo and metastatic disease, immuno is the drug of choice. But if you look at the PFS, it is almost exactly the same. It is not better. But the overall survival is dramatically better. So that's why we are learning in immunotherapy, do not rely only on PFS curves. It may happen that the PFS will be exactly the same, but because a small percentage will respond durably, your overall survival will pick up. So that's why in immunotherapy, we say look at the OS curves, don't look at PFS curves that much. One needs to look at both, but you look at PFS because you want earlier data sets. That's the reason why you look at it. But in immunotherapy, it is very, very different for various settings. It is not the same. OS is more important. And that's why most approvals start coming when the OS data comes. Most approvals don't come on PFS because sometimes PFS does not matter. Patients will not have PFS advantage and may still benefit, or patients may have PFS advantage but no OS advantage. Adoptive cell therapy. So this is the way the field is moving again. You're looking at various ways of stimulating the immune response. The adoptive cell therapy is another way of doing it. But again, it's much more complicated. So that's the reason why we like checkpoint inhibitors. You're not really having to remove cells, send them, culture them, make antibodies grow, try to manipulate them, and then give them back. This is not what we're looking for. We like off-the-shelf products which are available to us in the market. Just take it and give it. So adaptive cell therapies will be there. Yes, it is being looked at in various cancers. You've seen the prostate results where approvals are there. You've seen the newer data sets coming out from renal cell cancer. But I don't think that's very important for us. I think more important is what is a checkpoint inhibitor as a drug available for usage. So if you're looking at the new treatment options, what you see for for myeloma, suppose you have CAR T cells where you have to do a whole complicated procedure of taking the cell, create a CAR T, and then give it back. It's immunotherapy. In a way, you're giving the immune system back in various ways. But that's not where we are fascinated by. For us, fascination is the bispecific antibodies in myeloma. They're off-the-shelf products. You are giving a monoclonal antibody which is having two arms, holding binding its two sites, and that is giving us very good results. So for us, off-the-shelf products is always better than trying an adaptive cell therapy. What is good marker, CPS or TPS? No, so there is no straightforward answer for one cancer. You have to see the type of cancer and then choose. For lung cancer, it's TPS. For many other cancers, it is CPS. For most cancers, it is CPS, and for many cancers, it is no Pdl1 marker. Endometrial metastatic lenvatinib pembro or pembro alone in MSI high. So MSI high in endometrial cancers, I would say pembro alone is equally good responses. You can have very good responses. Lenvatinib to pembro may increase your response to some extent, but pembro alone is also very good and very potent. So MSI high tumors, you have to see a few patients to see how dramatically they respond. We have had endometrial cancers with bad cancers, just given found MSI high, given pembro, and the tumors have just shrunk off. So these cancers, I would say lenvatinib increases your response, but lenvatinib also increases a lot of toxicity. The quality of life has to be managed. So that's the reason why MSI high endometrium, I would say give a trial of pembro alone. Yes, if it doesn't work to your response criteria, you can think of adding lenvatinib, but I would start with pembro alone. Stage 4 nasopharyngeal carcinoma, any role? So again, a sitting where yes, it could be attempted. Chemo in combination with immuno can be attempted, but again the data set is very variable, but it can be tried. So I think we have covered all the questions.
Yes, Dr. Amit, thank you very much for the presentation, and thank you very much, trainees and faculty members, for joining us.
Thank you. Thank you.